So, what about the endovascular alternative to treat CFA? In fact, in all these studies, they use angioplasty to treat this highly calcified lesion. And definitely, in this case, POBA doesn't work to treat CFA because it's so calcified. As previously we show about calcification, we have huge amount of calcification, we have bone, and so we have elastic recall, and we have not good results. Regarding other alternatives, we can use some scaffolding, and all these studies have used scaffolding, and it seems to have really very good and promising results in case of scaffolding use, because we can deal with the huge amount of calcium at this level, coronal reef calcification. They could prevent early recoil, but we have some concern about the future of this stent due to the mobility of this zone. But if you look at this zone, you can say that between the circumflex artery and the ostia of the SFA and the deep femoral artery, it's a pretty fixed segment, and we have no movement at this level. So my colleague Kuhn has established this study, VMI-CFA. VMI-CFA trial is a prospective multi-center single-arm trial to evaluate the Supera peripheral vasculomimetic implant device for symptomatic Rutherford 2 to 4 patients with CFA stenosis or occlusion. The primary endpoint of about first efficacy is the primary patency at 12 months, and the primary endpoint about safety is the periprocedural adverse event at 30 days. Now, about the inclusion criteria, they include a Rutherford patient 2 to 4. They include also de novo and post-restenotic lesions, stenosis superior to 50%, and also CFA occlusion. The patient should have a DFA patent and a good SFA runoff. They exclude from this study patients with Rutherford 5 to 6. In stent restenosis, they exclude also patients with previous open surgery of the CFA, occluded deep femoral artery or SFA, and non-treatable inflow lesion, lesion with thrombus, and finally, they exclude the use of debuckling devices or drug-eluting technology. To do this study, Kuhn uses the ASEMA classification, so we have 4 types, and they include only 2 types, type C and type B and type C, I mean. In type B, lesions are just located at the common femoral location, and in type C, the lesion involved the common artery-femoral bifurcation. So mainly in close to 80% of the cases, patients were claudicant, and the mean reference vessel diameter was 7.29 millimeter. And if you see the vessel preparation, the mean diameter was 7.19, and the mean diameter of Supera stent was 6.48 millimeter. Now, regarding the survival at 2 years, it is 85.5%. Regarding the 2 years primary patency, it's 92.8%, and it didn't see any difference between ASEMA type B and type C types in terms of patency. Now, regarding freedom from TLR, at 2 years, 97.8% of the patients were free from TLR. And about TVR, at 2 years, 84.3% of patients were free of TVR. About symptomatology, at 2 years, mainly patients were claudicant, and they also observed a sustained increase of EBI at 2 years. Finally, about the safety evaluation, at 30 days, we have no safety concern and only 2 reinterventions at 2 years. So according to this data, Kundelos and his team have set up the SuperSurge RCT, which is a randomized study comparing stenting with Supera versus open surgery. So to conclude, in 2019, although CFA still remains the golden standard, the historical no endovascular for this baby statement is wrong. There are some indicative papers that show there is definitely a place for safer and efficient endovascular therapy in CFA treatment. Newer generation of devices like high-crust resistant recopunctable Supera stent are facilitating the endo approach. With this particular device, the VME CFI trial show excellent 2 years results, primary patency high, and also a low rate of TLR. And finally, the head-to-head super surge RCT is coming soon. Thank you for your attention.